think it's about time to kick off. So good morning, everybody. Welcome to today's webinar, hosted by myself, Alex Templeton. I'm the co-founder and CEO of Qured. Dr. Kish Vithlani, who is our medical director, and Nick Reeder, who is a lead consultant over at GoodShape. Today we're going to be discussing, hopefully not a contentious topic. Hopefully it'll be a very constructive conversation, but we're really looking at the challenges around the traditional models of occupational health, where they're lacking, where they haven't perhaps been able to quite keep up with the rapid shifts we've seen in how we work today as a modern workforce, and the specific health challenges that we all see within our working populations. So just to give a little bit of an introduction on us first, we're Qured. We are a technology company, and we've built a prevention as a service platform, which powers better lives through preventative healthcare. So we work with large employers to help them understand the health risks within their population, to help them analyze how those risks are going to evolve over time and how they can intervene early to target and mitigate those risks, which is to everyone's benefit. So it helps employees live longer, healthier, happier, and more productive lives, and it helps businesses reduce those costs and risks associated to poor employee health. Nick, do you want to hop in to introduce GoodShape?
Yeah, sure. Good morning, everyone. On a very similar theme, really, GoodShape is a technology platform that we built basically from our sort of 20 years experience in the sort of health and wellbeing industry, really to address the issues associated with managing absence and really improving employee health. And we do this really, again, it's all data driven, and the platform looks to sort of streamline workflows, enhance the support that employees, managers, and HR get, and really sort of automate a lot of the administration, with the end goal being sort of data insights that give clearer outcomes to organizations, HR, OH teams, and really to sort of highlight the impact, be it positive or negative, that those flows are having on individuals, and linking that to the bottom line of organizations, which is really key to drive forward further investment in this space going forwards.
Yeah, no, I think you're so right. It's about obviously supporting employees and doing the right thing. But also you've always got to tie that back to what is this doing for the business? And I think that's a really important commonality between our two companies and how we really built everything that we do ground up to serve large employers.
Yeah.
So the problem that we're really both addressing fundamentally is this huge crisis in workforce health in the UK. So that's what we do. That's what GoodShape do. And of course, that's one of the main problems that that occupational health is tackling. What's really clear has been that this is a situation that has been deteriorating dramatically over the last few years. So before COVID, back in 2019, we had 2 million workers who were inactive due to long-term ill health. That has grown to the present day to 3 million. I mean, we're talking about close to 10% of our workforce at this point. And that is projected to grow over the next 3 years by another million. So having essentially doubled in just over a decade to 4 million. And this cost is becoming a huge burden, obviously, on the state, but also to the economy and to employers. This is a £100 billion a year problem. So what is driving this issue? Why are we seeing these huge increases in long-term absence rates that are obviously having a really catastrophic effect on employers and their ability to run their operations effectively?
So I think there's...
Sorry, Kish, do you want to start with that one?
Yeah, I think, I'll tell you from a clinical perspective what we're seeing as the main drivers for this, and Nick, I'll hand on to you afterwards, just so you can give your insight as well. But there's a huge range of problems. It's not just one thing. It's also not just a workplace-related issue or a home-related issue. We're going to look at the whole biopsychosocial, the biochemical aspect, the psychological aspect, the work aspect, the social aspect as well. So And the kind of conditions that we're really seeing is, chronic conditions. So we're seeing a lot more diabetes, heart attacks, strokes, things that what we associate with metabolic syndrome. And at Qured, we do a lot of metabolic syndrome education, screening, testing. That accounts for quite a large amount of the problem. And this is something which is very much preventable through early identification, through early testing. That's one aspect of it. The other is MSK problems. And traditionally, we think about MSK problems related to more laborious roles, but actually we're seeing a trend with more sedentary work, with people working from home, with more, jobs involving sitting down for prolonged periods of time. That's leading to MSK problems, mental health. And it's not just, anxiety, depression, it's stress, it's burnout, it's workplace pressure. That all comes under that umbrella as well. And there's also things like delayed diagnoses. So, we're seeing that the NHS is under, a huge amount of pressure. There's, increasingly longer waiting times to be seen, to be diagnosed with things. And that's resulting in delayed diagnoses. And you can sort of categorize it into these 4 or 5 different segments and why we're seeing the drive in these increasing absence rates and the costs as a result of it.
Yeah, and interestingly, that chimes with the data that we collect. Obviously, ours is very sort of absence focused, but it links in with a much wider and broader data set. But in terms of the actual impact that what Kish has been talking about has on organisations, we've seen a marked increase in the number of days lost or lost working time across organisations. And the example on the slide is from 2018 to 2024, where we've seen an increase of 21%. So we're averaging around 11 days lost per employee, with a cost to the organisation of around about £2,000 per person. So it's quite a significant cost when you sort of times that up across these large 1,000 into the tens of thousand employee organisations that we work with. We're also seeing an increase in the rate of turnover of staff due to ill health, and that's increased significantly by 14% in that same period. And then obviously the associated costs with that, things like group income protection, have increased significantly as well. And that's all due to the length and the number of spells of long-term absence that we're seeing.
So not only are people dropping out of the workforce due to ill health, but the workers who are active in the workforce are taking more time off due to ill health as well. So it feels like a problem that's spread across the entire working population. Mm-hmm. And just digging into what kind of health-related risks are businesses having to manage. What are those key drivers of costs in the business? And how do those costs essentially break down?
Sure. So again, you probably work out that I'm pretty geeky in terms of the fact that I keep relating back to data, but I do think it is the fundamental kind of foundation of any sort of health and well-being strategies, is to understand exactly what's happening with your people within your organization in real time, and not just real time predictively, which is another area that I can come on to later. But it really is about, so looking at the next 12 months within an organization, what are the very likely accurately predicted health issues that we're going to see? And by focusing on that with real clarity, but also very high accuracy, it allows organizations to really understand potentially what's coming down the road, and what services and what interventions, much like your service, what proactive things can be put in place to head those off, either very quickly or even before they happen. So for this example, if you can just click through slightly further, up with the boxes. Here we go. So what we typically see is around about 70% engagement of an employee population with our service across a year, because 30% of employees have no issues at all within that 12-month period, so we don't get to see those. However, 43% of employees have very disruptive, persistent, short-term issues, which you have to handle in a slightly different way. And then 27% will have serious health issues, sort of life-changing conditions. Much to Kish's point, we've seen a sharp increase in mental health problems, and musculoskeletal injuries are still right up there in terms of the top reasons for absence. So again, just having a data-led perspective very much helps to focus, whether it's HR or occupational health, on what the issues are. And we all know that HR and OH are doing a fantastic job, but within an arena where they're stretched, there's limited resource, and a lot of that time is taken up with administration. So it's about where can you focus to have the biggest impacts and help employees with their health in the most significant ways.
And Kish, what kind of risk do we see when we're screening in the population, and how does that translate into costs for employers?
Well, actually, going back to the same slide, we can really relate to that. We see what we're seeing from what we're testing is a lot of things that are, putting people at risk of long-term conditions. So, that section where you saw the life-changing and the emergency, causes of absence, that's something where we're seeing, the most amount of impact. Really, we're seeing all these risks that are increasing, the likelihood of getting diabetes, stroke, heart attacks, premature death, Alzheimer's, dementia, all that sort of stuff, all related to metabolic syndrome, from things like having high cholesterol, having increased risk of insulin resistance and diabetes, having impaired kidney function, having abnormal thyroid function, and all these risk factors come together, which at a distance may not seem like much, but when you really delve into the biomarker data and also combine that with the sort of personal data that we're getting from individuals, we're seeing a huge amount of information that suggests that these people are at risk. I mean, looking at the data aspect of it, we're seeing about above 80% that have at least one abnormal biomarker. Around half have more than one abnormal biomarker, suggesting at least there are things that are going on underlyingly. And actually, if you do take a preventative approach and screen these individuals, you can identify what's happening at a much, much earlier stage.
Well, why is that important? Why is it important to pick these things up early?
Well, if you pick these things early up, you intervene earlier, then you can really avert that risk. People that are on this trajectory to developing these conditions can really be pulled back from there and get them back onto the right track, so they don't end up having a heart attack, don't end up having a stroke or developing diabetes. And we provide the clinicians that give these insights, the health coaches that can really pull these people back from this trajectory to having a high risk condition, getting them back on track and making sure that it doesn't result in early retirement or prolonged sickness absences. So there's a huge benefit there. And these conditions, so emergency conditions and life-changing conditions, this is the area which accounts for the longest period of absence, and also it's the area where there's the highest amount of impact from doing preventative screening.
Thanks, Kish. So Nick, I mean, occupational health generally seen as a force for good, right? It's generally seen as supporting employees at their time of greatest need, and offering it and having a robust provision generally kind of marks you out as a kind of supportive employer and someone who cares about their employees. So can you talk us through a little bit about the traditional models of occupational health, and why is something that, optically seems like a great thing, how has it really been falling short, and, where, in your opinion, does it need to change?
Sure. Well, I think it's important to say, obviously, the title of today's webinar was quite a provocative one. And actually, I've worked with, I know a lot of OH professionals, nurses and doctors who are brilliant at their jobs, very professional. And look, but anybody who spends their working life trying to better the health of individuals is a hero in my book. What I meant by the sort of OH piece is it's a bit broader. It's more about the framework in which occupational health operates. And it's been around obviously since the 70s, where it's very focused on work-related issues. And actually, as to sort of your point and Kish's point earlier, these days society has changed, and we're certainly seeing an expectation from employees that their employees should look after them better and should be more aware of the whole social and welfare element to the support that's given, as well as just sort of support within the working environment. And the traditional occupational health model is very much about assessing people based on their job and their fitness for sort of to be able to carry out that job. Whereas really the remit is much broader now in terms of understanding what's going on outside of work and how employers can help those individuals. So it's much, I suppose it's moving towards sort of more of a case management, healthcare for all model, where and with systems like ours, you can link into many other services, and with the data insights that provides, you can give OH professionals much more information around what's available to that individual and what onward services that they can be pushed into, be that third sector or charities, or be that linking in with NHS systems so that you can expedite operations. There's a whole raft of things that could be done to help, which I think is the kind of direction in which occupational health needs to travel, and in some cases is, but it needs to do that in a much broader sense.
Yeah, that makes total sense. And I think really work, you don't leave your health concerns behind the moment you step outside of work, or vice versa. And I think taking a holistic view of people's health and actually giving them the support that they need to make meaningful changes has a massive impact, obviously, both for the employee, but ultimately for their employer as well. And I think this is an area where I think the market is advancing and solutions are advancing that really takes that into account.
Yeah.
So looking at kind of what does a new model look like? I mean, what does taking a data-led approach to employee well-being and absence actually look like? How could you create a unified approach through this predictive and proactive health support, and then rapid intervention and use of data to drive those outcomes in terms of return to work? How might you tie that together, and how's it actually being implemented in real terms? Kish, do you want to talk through a little bit about Qured, and then we can see about how it sort of dovetails into to GoodShape?
Yeah, so at Qured, the way we provide this sort of service is by ideally having a workforce-wide sort of program where we try and get as many people involved as possible. We offer a fully remote service where all your health screenings are done at home, guided by a health coach, all remotely. You get blood biomarker data from the kind of risks that we want to test for. So as I said before, things like all the risks of metabolic syndrome, certain cancers, diabetes, all that sort of stuff. We collaborate that with the personal information about somebody's lifestyle, about their stress, their sleep, their nutrition, the mental health. We collaborate all this data together. Once we've got that all that information, we can risk stratify these individuals, determine what the risk is of having a heart attack, stroke, diabetes, certain cancers. And when we give these results back to the individual, we can do that early intervention piece through our clinicians, where we tell them what they need to do to get back on track, avert that risk, and prevent them from having a life-changing condition. Or if there's something else that we pick up during that consultation, how to get them back into the right sort of care. What can we do to provide them with necessary tools to get back on track and prevent them going off sick or having a condition which might make them go off sick. And the way we quantify that is, well, all the data that we have anonymized data. We give that information back to the employer, depending on the route or the function or the region, and we can really categorize where the input needs to be, where the interventions need to be, to actually improve the health of the entire workforce, not just on an individual basis.
So I think it's that data is key. So the kind of data about what is driving absence and those risks in the population, that feels like something that employers haven't really been able to access before. and actually is something that feels really valuable to them as well, you know, around creating a data-led well-being strategy, around understanding where their risks are, but also how they can best mitigate those risks. So what are the targeted interventions? What is the signposting? How do you create journeys for employees to reduce those risks in the first place before they tip over into an absence in the first place? But when they do, so, you know, that's where probably the data we're collecting, the risk stratification, overlaps with this predictive analytics that GoodShape are putting together to give a really holistic view of what the risks are in the population and who you really need to be looking at to support. But obviously, you can't keep everybody healthy all the time, though we try. And what happens next, Nick, when somebody does actually tip over into a long-term absence?
Yeah, with the GoodShape platform, it's really about giving employees access to be able to report their absence and get advice and putting the proper processes and procedures in place so that it doesn't matter who you are and where you sit within an organization and who your manager is, you've always got a fair and consistent approach to how that process is managed. So typically,
how does that differ to a regular occupational health flow? I mean,
what's
different about it?
To be fair, you know, with occupational health typically doesn't necessarily get to see individuals right at the front end of that process. And that is one of the aspects that hampers the occupational health service, which is out of occupational health's control, is that sort of early intervention and signposting piece into the occupational health service. And there's a lot of inconsistencies there across organizations in terms of whether it's HR that needs to refer someone in, or is it a manager? When do they refer? Are they authorized to refer? What are the costs associated with that? So there's a lot of barriers to employees actually being referred into that occupational health service in the first place. But what you need to do is try and break down those barriers. And again, back to the data, when you take them through a process which is very structured, and you're making sure that you're capturing all of the relevant data and justifications early in that process, it makes it a lot easier to justify that referral into occupational health through sort of a triage and signposting process. That's where the sort of the case management comes in, and providing those sort of provisions with a lot of data and context around who that individual is, what their absence history looks like, what services are available to them on an ongoing basis, can help inform a much more detailed conversation and much better outcomes for the individual. So it is that kind of wraparound of data that can justify all of those elements of the service, right through to that sort of return to work piece, making sure that that's done properly, so that the individual feels supported, the organization is on top of what's happened to that individual, and there's kind of an audit trail through all of that process, so you can take learnings from it, plug it into things like the predictive analytics, which then, which I'll come on to, but then sort of looks at what's potentially coming down the road, and that then links back in again to yourselves and the kind of services that you provide, but maybe in when you've got your whole of workforce, but then there'll be elements where it needs to be more focused and more structured, and you can do that with the data insights that it's providing.
So just digging into those data insights, like what kind of costs are we seeing for businesses, and what kind of data are you seeing when you're working with individual organizations?
I mean, not surprisingly, with large organizations, it runs into the millions. And this is just an example of sort of an anonymized client where basically we looked at individuals, the sort of top 100 in terms of long-term absence within an organization, and who of those had been referred through to a service and who hadn't. And there was a marked difference in the average length of absence between the ones that had been referred through and the ones that hadn't. And then there's a process that you would go through there about understanding why the individuals that hadn't been referred. And there's a number of different reasons there, but the blockers are usually financially related. So to break those blockers down, the best thing that you can do is show the associated costs between the difference. So in this example, that's 42 days difference. What on average is that costing the organization? And typically, you know, it's kind of 4 or 5 times as much as it would have cost that organization to make the referral in the first place. So it's really about giving HR and managers the tools to push people through those processes quickly and early on, so that to Kish's point earlier, you can head things off before they become much worse problems, but you do that in a way that the board or the exec of an organization can understand in terms of what the impact is and what it's costing the organization.
Yeah, that makes total sense. And I think it's always tying, as we started at the top, it's always tying back what the aggregate improvements are in terms of the bottom line for the business. And I think that's something that we really focus on at Qured as well. And we've brought together a lot of remote technologies, remote blood collection, telemedicine, AI tools, which help us with risk stratification. And we've brought this all together to orchestrate something that drives huge uptake from employees and sparks real behavior change. Kish, do you want to talk a little bit about the impact that we've seen as well in terms of the starting point, typically of some of those levels of abnormalities and essentially, risk of being on track for major disease, and how we've been able to help people turn a corner through engagement with the program?
Yeah, well, we can really divide this into looking at it from 2 different angles. We can look at it at an individual level, and Robert Alton is one of our clients, and he's one of many who's actually made so many changes to his lifestyle and actually improved his health through all the coaching and the clinician input that we delivered, along with the biomarker insights. So over a course of 6 weeks, he lost 10 kilos, walked 200 miles. He's completely changed his life, and he's really averted his risk of having a serious chronic condition that could have had a huge impact on his life. But looking at it from a organizational level, from looking at the client data that we have, 10% of the people that we saw required an urgent referral. So when I mean urgent referral, this is something that required an intervention over days to weeks rather than weeks to months or months to years.
And this is across, thousands of employees across dozens of companies, right? But we're seeing consistently 10, even on average 10% of employees that actually have a condition that they were completely unaware of that required onward treatment. And I think that data really stands out because it just chimes so much with those absence rates, soaring absence rates we're seeing, those people tipping over into long-term absences, people dropping out of the workforce altogether. It feels like the population is really sick and really struggling, and I think that's probably why new thinking is required.
Absolutely, and as you said, there's 10% is the average, but actually, if we were to break it down to those that are working night shifts, doing shift work, actually that referral rate for urgent referrals is going up to about 15%. So these are the people who are sort of our safety critical workers who are at the very highest risk, and that's where the biggest impact needs to be delivered, really. But it's not all doom and gloom. What we have seen as well is that offering a program like this, giving the people the knowledge about what the biomarkers are, what their risk level is, offering them the coaching through clinicians, that actually people can make huge changes. 90% improve their biomarkers across multiple biomarkers when we compare it to the second year biomarker data. 45% of the people we surveyed, so they stuck with the changes that they made over a 12-month period. That's much bigger than what you'd expect from, if you asked a bunch of people how many people joined the gym and stuck with it for 3 months, over half of them will probably say they've stopped going. But the lifestyle changes that we can deliver through the consultations that we give, people are sticking with it. And this sort of develops into the sickness absence data. A 20% reduction in sickness absence data after Qured has been delivered, and this sort of program has been given to the workforce. So the impact is huge, and there is a huge ROI from offering something like this. And I think the way we frame this needs to be changed. Occupational health traditionally is a fitness to work thing, but actually we need to sort of frame it more as an employee benefit or employee well-being to actually deliver the kind of impact that we want to see.
And so looking at the kind of program that GoodShape are running and what we do, how does that ROI stack up to a traditional occupational health service? I mean, what kind of, Nick, I'll pose this one to you. What kind of ROI does occupational health generally deliver to a business, and how's that measured?
I think traditionally those dots haven't been linked. So I mean, there are there's clients that we work with that do link those dots because of the absence management service and the data that gives an organization. But typically, when we're talking about absence management, that is quite old processes that organizations have as well, whether if you've got a HRI system, they're reliant on managers. It's a very admin heavy process with a lot of gaps in it, so it's very difficult sometimes to get to that depth of data analysis for organizations in terms of what outcomes and what ROI is being delivered and what impact those occupational health interventions are having. I mean, we know broadly across the entire service, we typically see around about a 25% reduction in absence over 12 months. So you add that into your preventative, as well as the impact that occupational health can have with more assistance in terms of what's being sent in and the early intervention and signposting. And occupational health would have a significant impact on absence reduction. But I think getting to an actual figure, we found pretty hard outside of our absence management service. Once you plug that in and you have all of the absence data and metrics, then you can start to look at the impact of somebody going through process X versus somebody going through process Y.
And Kish, what kind of impact have we seen in terms of business ROI and outcomes, and how do we measure that?
So the way we measure this is we'll from the information that we get in terms of the biomarker abnormalities that we're seeing, and from the sort of the personal information we're getting, we can create a risk analysis of what an individual's risk is of having metabolic syndrome, for example. We use that along with hazard ratios from clinical data and clinical studies, and then we can predict the risk of somebody developing one of these conditions over a 5-year period. And using that data, we can tell a business on what the implications of that might be, depending on the cost of an average sickness day within the organization. And we've seen actually a huge benefit. We're seeing a 5-fold return on investment from the data that we've got, and this is all backed up by strong clinical data and the hazard ratios that we're seeing from the risks of these individuals, but at an organizational level.
Thanks, Kish. And Nick, question in from Adam, and very much I think in your wheelhouse. When you're referring to case management, can you go into, just before we move on, could you go into a bit more detail about how this it would impact an employee versus a traditional OH pathway, and what data have you got to back this up?
Yeah, I mean, we say case management, it's a bit of a broad term. It's more kind of health. It's more of a healthcare for all provision across an entire workforce. And we've got data for existing clients where we've seen long-term absence reduced by 50% plus over previous years. And really, that is, again, it's not about trying to knock occupational health as a service or the individuals. It's more about the facilities and the platform that they have available to be able to link into other services, as I mentioned before, like the NHS or GP provisions or charities. So it's not just about offering advice to managers on next steps, but it's actually getting involved in those next steps and what that process looks like, and linking individuals into those other services and making them aware, because most organizations have a fairly decent health and wellbeing provision. It's just that employees aren't typically aware of them, and certainly not at the point of need as to exactly what's available. But outside of that, in terms of that social and welfare piece, there's also a lot of services out there in the general public that you can plug people into. So again, it's just having a much better understanding of not just their working environment, but their life outside of work and what's going on, to be able to, basically the employee then feels a lot more supported and more engaged with the organization, and the organization benefits, again, looking at the data and taking it back to that sort of productivity and efficiency piece, great improvements in all of those metrics.
Yeah, I think I saw earlier you had some data on cases closed and reduction in long-term absence for these specific employees going through that end-to-end process. Do you have are you able to share a little bit of on the improved outcomes and how you measure that?
Yeah, so again, it's just, for us, because we've got that end-to-end piece, we know when somebody's going off, we know when they're going through any of the processes, and we know when they return to work. We have that sort of those end-to-end metrics. And over the years, we've got more than 1.2 billion data points that we can use to look at what the average length of absence is for an individual based on the reason that they're off. And then we also, because we link our system into other systems and services, we can see when they've been signposted into a particular service, how long they're in that service for, and when they come back out, and what the outcome of that is. Have they gone back to work? Have they gone back on reduced duties? Is it ill health, early retirement, etc.? And we can build those metrics in to show what's happening within the organization. And then it's almost like steering the wellbeing strategy going forwards. I'll talk a little bit about predictive analytics, but that's more about where should we be focusing our resource, and how do we justify, if we're going to go and ask for more money to spend on a particular service, how can we show that that's going to have a positive impact and affect the bottom line for the organization.
Thanks a lot, Nick. And we got some great questions coming in as well from some of the attendees. If you do have anything that you'd like either of our experts to answer, please do just pop that in the Q&A channel. Here's a good one, and this is obviously a big part of my job, and I'm sure yours too, Nick. How do you get the board in a company to invest in a whole of workforce solution? I can share a little bit of our experience, and it's very much, again, it's data led, and being able to quantify the outcomes of what you actually do. We've heard so many times from large employers that we're working with that in the past they have taken a bit of a scattergun approach to their employee health and wellbeing strategy. They've got bought a few programs, no real interplay between them, no real data capture, and we've heard so many times, we don't know whether this has done our employees any good, let alone us as a business. We have no way of measuring that. So I think flipping that and starting with the data and starting with, okay, where are your problems? How are we going to quantify those? Here's how we're going to model out how we're going to mitigate them, and then measuring that and sharing that back to be able to prove out that link between employee absence. Well, actually, when you reframe it, it's about employee availability and productivity, and how, as you improve those two things, tying that back to the economic drive for the business. So most boards, yes, they do care about the softer metrics. They do care about whether staff feel supported, and obviously that feeds into that staff turnover and churn piece. But of course, they care about, if I am putting £1 into this kind of program, £1 into Qured, £1 into GoodShape, £1 into another program, what am I going to get for that? And when you can prove out those two things for them, yes, it will have an impact on the employee. We can prove it in the reduced risk scores, improve, and reduce absence rates. And how does that translate into an economic output? And being able to prove that out with data behind you, I think, is the only way that you can convince all of the stakeholders on a board to actually invest in something that maybe they haven't done before. Nick, does that chime with?
I couldn't have put it better, Alex. I think that's exactly the approach to take, and really, it is just that getting the board's attention and engagement through data analysis and breaking down. There's a lot of silos in large organizations where information sits but isn't necessarily linked together. So it's about that sort of doing a full assessment of what a snapshot of what it looks like now, using the data to evidence what good looks like, and linking the dots between the two.
Agreed. And, it's great when you get the self-reported data from employees, through our program, 3/4 of people going through the program notice improved physical health, weight loss, better sleep, better energy levels, which is all great for the employer. And people reporting better mental health, feeling more in control, but actually great, the self-reported data, but really it's that hard data. What are the outputs? What are those metrics that a business can manage and care about? That does drive those outcomes for the employer. And you talked to, I mean, how do you use this data to take a targeted approach? I mean, where do you start when you're looking at an employee population, and how has that sort of worked in reality?
Yeah, so much as the slide says, we kind of use focus lists from our data within organizations. And this is a typical example of the fact that around about 2.5% of the headcount of an organization will typically make up 40% plus of the absence. So that feels to me like a natural place to start if you want to have the biggest impact in the shortest amount of time. The example in this organization, they had 12,000 days lost, which equated to 84,000 hours, and there's an estimated operational cost of 1.4 million. Now, if you focus on this area and that whole piece around early intervention and signposting, you can have a significant impact. And for this particular example, there was a prediction of a 41% reduction from the current absence rate. So it is significant in terms of what you can do. And that whole focusing down and then the predictive element and then feeding back into services such as your own, just in a cyclical way, will just over time reduce absence down. But once you get absence down to much more manageable levels, it's then about keeping that focus on it and maintaining those lower levels of absence.
Yeah, absolutely. And, I think you've shown here that there is a direct link between absence and staff turnover, which is really interesting because it's in some ways, you've got people dropping out of the workforce because of ill health, but actually are people leaving their jobs for other jobs, for other roles, based on, their personal health? Is that something that you've seen?
Yeah, and I mean, what this shows, it's not, people won't be surprised by what this slide is saying, but actually, I still think that there's a very strong case for being able to show that in a great level of detail and evidence it through the data, because then you'll get the sort of your exec and the board to stand up and pay more attention. So as you can see, there is a very strong correlation between the absence rates and staff turnover, not surprisingly, but it's there in the data. And also a good example in terms of mental health, as we all know, it's the largest reason for absence. Currently, it used to be musculoskeletal and then mental health, but they flipped round. And we know that the risk doubles with mental health absence if they have one incident within a year, and then it triples if they have 2 or more incidences. So again, not surprising, but it's very helpful that the data bears that out, and you can do it very accurately in terms of what you're showing.
And we're sort of coming up to time, but we've got a few questions, so I'm sure if people are interested, we can tick over a few minutes. But it feels like this is the future direction of travel. We hear the Society of Occupational Medicine saying, okay, OH needs to shift from a proactive model, from a reactive model to a more proactive model of care that's fit essentially for the modern world, the new challenges that we're facing through how we work, but also the impact of our lifestyles on our health, because clearly that's leading to this deterioration that we're seeing in the workforce. Added to that, obviously, difficulties in accessing regular NHS services as well, because of how the NHS is struggling. What does taking a more proactive, predictive, and preventative approach, what does that actually look like? We've got some data emerging that shows this work, but how does that happen? How do these big OH providers pivot to really move into that that forward-looking mode.
So I think, go on, Nick. Why don't you go first, and I'll add in afterwards.
I was just going to very quickly say, I think that's down to sort of organisations to enable those occupations, whether it's sort of an in-house occupational team where the organisation they work for can enable that to happen, or if it's an outsourced occupational health team, the actual outsourced organisation can build those in. And just very quickly around the predictive, we kind of look at long-term risk, frequent absence, staff attrition, and we can forecast as far as 36 months ahead based on the very accurate data that we have. And we ran models with Deloitte that were coming out as 83% accurate. They partitioned 70% of the data, and then we're looking to try and model the 30% future data that we had, and it was coming out extremely accuracy. And that really is all just about informing occupational health professionals, HR, as to what's coming so that strategies can be built ahead of time.
Kish.
I think looking at it from a slightly different lens, I think having something which is workforce-wide, so a workforce-wide approach, baseline screening, looking at, going very broad, looking at cancer, hormonal health, some of these factors that actually are emerging as common causes of absence, looking at mental health, neurodivergence, chronic conditions I've talked a lot about in terms of, metabolic syndrome. Baseline screening is really important, and it has to be workforce wide, just so you can actually identify where the biggest need is. And once you know where the biggest need is, you can target your interventions appropriately, whether that's lifestyle coaching, referrals into the NHS, which is, we do that at Qured. We can write to your doctor, to your GP, just to integrate things a little bit better to drive that change and help these individuals in the best possible way. Getting people to optimize their medications, optimize their lifestyle. All these sort of things are really, really important. And also risk stratifying, giving people the knowledge and the insight about what their risk is the biggest factor for change.
Okay, I've got a few more questions where we ticked a couple of minutes over time, but I'll try and deal with them quickly if I can. So we've got a question on how to show ROI within a 6 to 12 month window. Cost control is such a big topic at the moment. Investing in new programs is challenging, and boards and financial stakeholders are looking for a rapid return on investment. I think from the Qured side, this is really about those 10 to 15% of employees who had something they didn't know about, a condition that they were unaware of, and picking these things up and creating those immediate referrals for earliest intervention. And, underpinning everything is the belief that early intervention is key and will always lead to more efficient and optimal outcomes for an individual's health. So a stitch in time saves 9. And we know that by following up and closing that loop, to your point, Kish, on what happens next and getting that data back, we can show what the value of that early intervention is and start to show that economic ROI very quickly. And of course, over a longer period of time, it's about the behavior change, getting people into healthier lifestyles, reducing their risk scoring. But obviously that comes in over a slightly longer period of time. Nick, is that something you guys are able to show, that early ROI?
Yeah, I mean, again, we're very well versed in terms of that return on investment piece, just because typically organisations don't have budgets for our type of service. So we've spent years working with organisations, and obviously the data that underpins that is extensive. So we can put together very solid business cases in terms of what it will look like over the next 12 months and what reductions should be expected, the current cost of absence to an organization for a number of different aspects, and how that will reduce over time and what the associated cost savings with that are, just again to justify it and really to lever that interest from the exec or the board.
Yeah, well, you can only manage what you can measure, right? So
Absolutely.
And for so many people, workforce health can be anecdotal, but actually once you've got that data, it becomes unignorable.
Yeah.
And once you understand that your costs are 5 to 7% of payroll, when you stitch it all together, actually this is a serious entry on your P&L.
And typically we see very similar ROIs to yourself, anything from 5 to 15% ROIs, type X times ROIs. A lot of that is dependent on where they're starting from and how high their absence is. So there's a lot of different factors in there, but the cost of absence pretty much for every large organization is so big that with the data you can fairly confidently justify.
Yeah. And thanks for all of you guys who are still with us. There are a lot of great questions to get through. It'd be a shame to cut off early. So if we can take another 2 or 3 minutes of people's time, let's get through them, because we want to answer everyone's questions. So what exactly would an employer or manager see on their dashboard about their staff? From our perspective, it's the first question that everybody asks when we're engaging with a company. What happens with the data? Is it anonymized? Is it personal to the individual? Yes, it is. The individual, all of their health data lives within their app. They, their manager, their employer doesn't have access to it. But we do tell people that we will anonymize in a GDPR compliant way and aggregate that data to give insights for the business into how that employee population is faring versus different comparators, benchmarking it against industry peers, benchmarking one sector, geography, or job type against another, to help the business really build a very accurate picture of the risks and where they need to provide a little bit more support. That data is there to help employers support their employees better. And I think people do understand that, but obviously are quite wary. So it's about engagement, it's about uptake, it's about specific risks for specific disease, but never presented in a way that would ever allow you to triangulate or identify who an individual employee was. I'm sure it's much the same with you, Nick.
Yeah, absolutely. It's I mean, a lot of the time our platform is very adaptable, so we adapt it to organizations' absence policies, but it's all done on the hierarchy of the organization, and there's permission levels on everything. So HR typically do have access to more information, but they do anyway. So we're just kind of mirroring what's already in place. Whereas a manager would only have access to the 7 individuals that they look after. And again, based on the access level, is how much information they can sort of see. A lot of the clinical information they just can't see anyway. And we do kind of, we also really sort of put the data into the system so that it's aggregated and there's a lot of sort of context given without necessarily going down to the finite detail. So it's very GDPR and ISO and all of those types of compliance metrics, so that only the relevant people get access to the relevant information.
Great. And final 2 questions. What is the government doing in this? Isn't this their role? And we know that the NHS is stretched, providing healthcare to the general population, but is difficult enough. Providing extra additional care to employees in the workplace is just not something that's on their radar or is feasible. So I think employers definitely having to step up and fill in some of those gaps and really get a grip on this problem themselves. But ultimately, if they're investing in this, certainly we, as an organization, expect that government incentives will emerge to help employers offer occupational health services, preventative proactive screening services, and general corporate health and well-being. And that's something that we hope to see emerge from the results of the Get Britain Working white paper, which we should hear about in the autumn. So very positive trend, we think, for the market as a whole. And I think that employers who, struggling with costs, budgetary constraints, this is hopefully something that will help. And one final question, Nick, this is probably more in your wheelhouse than ours. This is about people with long-term absence rates. People are sitting on waiting lists for treatment. Obviously 80-85% of the workforce doesn't have private medical insurance. How can you help those guys? How can you really help address those stubborn cases?
Yeah, I mean, there's some very sort of proactive services out there, certainly ones that we work with as well, where that are addressing that issue. And the main issue there is that the NHS trusts themselves just don't have the capacity. There's things like, there's a lot of operation and cancellations that the trust just can't do anything about when it happens. But there's all certainly organisations that we work that are able to speak to those trusts and access that information, so that, you know, Joe Bloggs is waiting 8 weeks for an operation, but actually one next Wednesday has been cancelled. It's those kind of practical steps that you can take and be proactive about it to reduce the duration of those things. There are things that can be done about it. It's just that typically the NHS themselves just don't have the capacity to do it. So I think the onus is on us as healthcare providers to work with the NHS Trust, which, you know, NHS in general, which is a jewel in the crown, just in any way that we can to help facilitate it being a more productive and efficient service. They do a great job, but they just don't have capacity for some of those more sort of practical elements.
Yeah, and I think learning how to integrate more efficiently and effectively to the NHS to avoid duplication of services, to ensure efficient referrals, is going to lead to better outcomes for everybody. For the employee, clearly they get seen sooner. For the NHS, they get to see somebody when they're presenting with a less acute expression of the issue. And of course, great for their employers and their families too. And so that's why we do it. It's a great role to play. Thank you for indulging us, everybody. We have run well over, but that was a function of all the great questions that you've shared. We will, yes, absolutely circulate the slides to everybody who attended today, along with a recording of the webinar for those who weren't able to join us. But on that note, I'd just like to say thank you to everybody for attending today. Again, some great questions, really thought-provoking. Thanks to you, Nick.
No problem.
And thanks to you, Kish. It was a really lively discussion, and hopefully more to come.
Great stuff.
Thank you, Alex.
Thanks, everybody.